Good morning, everybody. I had to talk against the neoadjuvant therapy prior to surgery for intrahepatic cholangiocarcinoma. See, the intrahepatic cholangiocarcinoma, it represents the very small group of patients, that is 10 to 15% of the all primary liver cancers. And in Western population, it occurs on the background of the PSC, and in Asian population, the main causes are hepatitis B, C, alcohol, and recently because of increasing incidence of the NAFLD, also the incidence of intrahepatic cholangio also increasing, and most of they are occurring on the background of the cirrhotics. Most of these patients present with late and locally advanced stage, so mostly 20% of the patients are resectable by the time of diagnosis. Till date, the liver resection is the backbone of the any curative intent. I'm just repeating, curative intended therapy of the intrahepatic cholangiocarcinoma. And even after surgical resection, the median overall survival reported in the literature is 28 to 30 months with 5-year overall survival of 30%. And the median recurrence-free survival is 20 months, because even after curative surgery, because this is the pure tumor biology, almost 50 to 60% of the patients recur, and most of the recurrence occur in the liver. And if you see other side, if in inoperable cases, the 5-year survival is only less than 5%. This was a systemic review meta-analysis published in the JAMA 2014, and it was almost analyzed more than 1,000 patients in the 56 studies, and they analyzed the poor prognostic factors. And this is the graph showing the different hazard ratios for all the factors, and the factors are the old age, male sex, large tumor size. But nowadays the tumor size doesn't matter in the prognosis. Even the multiple tumors, I will come later on, the lymph node metastasis, vascular invasion, especially portal vein, hepatic vein, or IVC invasion. Positive surgical margin is the most important prognostic factor. In that, you have to divide into either parenchymal margin and the R1 vascular margin. And the R1 vascular margin has a poor prognosis as compared to the parenchymal margin. And next is the poor tumor differentiation. So while considering the resectability of any patient, you have to take into consideration all the factors, including the underlying liver function, nutritional status of the patient. If you see in today's era, if you see the major complications following surgical resection and either in hospital or 30-day mortality, this is a recently published systemic review meta-analysis. And the pooled mortality following liver resection in hospital is 5.9%, 30-day mortality is 4.6%, and 90-day mortality is 6.1%. And the major complication is 22%. And if you compare by Western by Asian population, in Western population the risk of complication is slightly higher. It is almost 6.8 to 7%. In Asian population, they have reported in 4.4%. If you compare minor versus major resection, the major resection complications are mortality is 6% and the minor is 3.6%, and slightly increased complications in, but still with on the background of the experience of the liver transplant, you can still do the complex resections and the anastomosis. If you see the intrahepatic cholangiocarcinoma, even after curative surgery, almost 50 to 60% will recur, and most of the recurrence will occur in the liver. So this is a multi-center study from Germany, and they have done repeat resections in the patients with recurrence following the primary section. And they resected total 113 patients, and they have reported 5-year overall survival almost 57% and median overall survival of 65 months. If you see the even grade of complication, the major complication is approximately 20%, and in-hospital mortality is 3.5%. While taking into repeat resection, we have to take into consideration of the CA19 level before the primary tumor undergoing resection, the R1 status, and the lymph node status. So still, even the recur occur with a good repeat resection, good selected candidate, still we can give a survival advantage by surgical resection. And see this, even the patients who are the primary, during the primary surgery, only few patients has, only 20% of patients received the adjuvant therapy, and also the before repeated resection, very few number of patients have received a neoadjuvant therapy. Now I will, to have a clear message, I will go with the case scenarios. We have two case scenarios. One is the 65-year-old female patient with known diabetic for 12 years, underwent prior history of surgery, and also underwent surgery for malignancy of the breast. She presented with the right lobe SOL, and the imaging showed that there was a SOL in the liver, on the right side of the liver, located in the segment 7 and 8. It was a large SOL, more than 5 centimeters in size. Underwent biopsy showing adenocarcinoma in the background of chronic inflammation. So IST showed fibrolamellar SCC. Her upper GI and lower GI endoscopy were normal. So these are the lab reports. LFTs were normal, platelet counts were 1,53,000, viral markers were non-reactive, and this is the tumor located in the right lobe of the liver with slight capsular retraction, peripheral rim enhancement. The imaging suggestive of unifocal, large, solitary intrahepatic cholangiocarcinoma. So diagnosis is 65-year-old with good performance status, multiple comorbidities, right lobe large, SOL, upper GI normal, ICG 3%. So we have two differential diagnoses based on the investigation, either hepatocholangio or intrahepatic cholangiocarcinoma. Now we will take a second scenario where there is a 51-year female, which is a housewife, presented with abdominal discomfort in November 2019, evaluated in Gangaram Hospital. CT showing two large SOLs in the right lobe, one in the segment 7, another in at the central area of the liver, encroaching over the left portal pedicle. So she also underwent biopsy. It came to be adenocarcinoma, and biopsy suggestive of the immunohistochemistry suggestive of the intrahepatic cholangiocarcinoma. The tumor markers were seen at an 89.2 and CA 1.62. So there, that patient, the plan for surgery, underwent right portal embolization, but because the tumor, the central tumor, which was in segment 4, was almost contact with or encasing the left portal pedicles, or the area of contact was more than 180 degree. So they reported it as unresectable. So that patient came to ILBS. These are their lab reports. Platelet count 2,98,000. Bilirubin is normal. Albumin level are good. So this is the imaging finding. This is the large tumor again in the segment 7-8, and this is the another large lesion in the central area of the liver. See the left hepatic artery and the left portal vein. Contact was more than 180 degree. So now I will come after how will you manage these patients. Now we'll go to the literature. If you see trend of neoadjuvant therapy, it has remained low. It's almost less than 10%. Over the years, it has increased from 3 to you take a 7%. But see the other side, predominantly still the large number of patients undergoing surgical resection upfront, followed by adjuvant therapy. Why this has happened? Because regarding adjuvant therapy, at least we have some evidence from the level 1 evidence. Though the intrahepatic cholangiocarcinoma, they are clubbed with other malignancies. We have 2 trials. Already Dr. Sridhar has quoted the BELCAP trial. But neoadjuvant therapies, we have only retrospective data. There is no level 1 evidence. This was quoted study, already quoted Dr. Sridhar. This is also a large number of patients from the National Cancer Database from the USA. If you compare this patient, that they have given a preoperative chemotherapy versus no preoperative chemotherapy, the more the locally advanced stage patients were noted in the preoperative chemotherapy. But we don't know whether they are resectable or they are unresectable. They have not defined the resectability criteria. So if you take the survival is even chemotherapy versus no chemotherapy is comparable, even after propensity score match, though there is a trend towards increased survival in patients with neoadjuvant chemotherapy, but was not statistically significant. Importantly, if you see the overall complication rate following surgical resection, the patient who have received preoperative chemotherapy, the complications are very high, 59% versus 39%. And in the readmission rate is also higher. It was statistically significant, 50.7% versus 4.8%. This is another paper which was recently published, 2021. Again, this is a data from National Cancer Database. Very small number of patients received neoadjuvant chemotherapy. Also the same, the patient with chemotherapy, they were locally advanced, but we don't know whether they are resectable or unresectable. If you see the survival, it is both comparable, and they did the subgroup analysis with locally advanced, that is stage 2, stage 3, that is T2, T3, T4 tumor. Basically, they are multifocal with vascular invasion, perforating the visceral peritoneum, involving the adjacent organ and lymph node positive disease. Even the subgroup analysis, their survival was comparable. This was the recent paper which has cancer Sridhar, Dr. Sridhar already quoted. But if you see, if you're able to do a R0 resection, there is no impact of the adjuvant therapy versus neoadjuvant therapy. So the timing of therapy doesn't matter if you do a R0 resection. If you do a R1 and R2 resection, they have compared according to the stratified with the therapy, and the adjuvant therapy has a survival advantage over the neoadjuvant therapy. And also they have a sub-analysis done with the size of the tumor 5 versus more than 5 centimeter. There was a no cerebral difference between the neoadjuvant therapy versus adjuvant therapy. So size of the tumor also doesn't matter for the prognostic factor. Next is a multifocal and the patients with large tumors with large tumors that is more than 5 centimeter and the multifocality. If you see their survival as compared to the solid tumor, this is less. This one, the recurrence survival also is less as compared to the solid tumor. But still, it is, if you take a 5-year survival, it is almost, that is 20%, that is 1 in among every 5 patients we can still cure with a surgical resection. And they stratified this patient with the risk factors, the number of lesions more than 3, lymph node metastasis, and poor tumor differentiation. If the patient doesn't have any factor, the still with upfront surgical resection, good survival advantage can be given. And even with one risk factor, the survival advantage can be given, that is 20%. Now would come to the major vascular resection. Most of the studies, if you take a guidelines, they contradicting the resection, but the recent paper published from the multi-center studies, and in that almost 120 patients underwent major vascular resection, and it was 21 patient IVC resection, 98 patient portable resection, 7 patient underwent combined resection, and interestingly only 20% received neoadjuvant therapy, the 80% underwent upfront resection. If we compare their in-hospital mortality, is also comparable, was no maxillovascular versus major vascular resection. Even the severe complications are comparable, and if you take overall survival, that is median overall survival, recurrence survival, they are also comparable. This suggests that if the patient will be able to give a R0 resection, even with complex liver surgery, we can still give a cure to this group of patients without neoadjuvant therapy. If you take a lymph node positive disease, again, some group has advised the lymph node is a bad prognostic factor and go for neoadjuvant therapy. If you see the lymph node station, the Japanese cancer group, they are divided into different stations. For all intrahepatic cholangio, the presence of para-aortic lymph node is a contraindication resection. And especially right-sided tumors, if you see the lymph nodes to the left of the celiac axis or located in the left gastric artery area, that also taken as a distant meds, and these patients are contraindicated for the resection. But hilar lymph nodes positivity, still you can undergo the upfront resection. And if you see the timing of chemotherapy, it has no impact on in patients with lymph node positive, whether you give a neoadjuvant or adjuvant, the median survival is similar. Now this is the recent review which is published regarding the conversion therapy, which is initially unresectable, converting into the resectable group. Again, as in pancreatic cancer, we have well-defined criteria for unresectable, border unresectable, but in intrahepatic cholangio, as there is no consensus. So there is no uniformity in the resectability criteria. Again, you see the conversion rate is very low, almost up to 20%. So because of this heterogeneity in the center to center and because of the selection biases. This was paper again quoted by Dr. Sridhar. This was recently published in the BJS. This is intrahepatic cholangio 186, locally advanced and resectable. Again, in this paper, the resectability criteria is not defined, whether it is unresectable or resectable locally advanced group. And they did give a chemo, and then, but we don't know, some of these patients in this group may be also resectable. We might have lose the opportunity to resect, and they go progression and they become unresectable. So resectable criteria not well defined. Again, there is a heterogeneity on the induction chemotherapy. Some patients received gemcitabine-based chemotherapy. Some patients received chemotherapy embolization. There is no uniformity in the management. So what is the current status of the literature? Is the neoadjuvant therapy. We have retrospective studies, very small group of patients. There center-to-center variability regarding the selection criteria with inherent biases. So we don't have the level 1 evidence. There are ongoing trials. Already Dr. Sridhar quoted, and it will tell the results regarding the use of neoadjuvant therapy in the resectable intrahepatic cholangiocarcinoma. The same, the National Incision and Liver Cancer Study Group of Japan, they don't recommend neoadjuvant therapy in the resectable patient. If you are giving to able to R0 resection, that means complete R0 resection, that is parenchymal, vascular, and with good future liver remnant with adequate inflow and outflow. And based on adjuvant therapy, we have some level 1 evidence from the BILCAP trial, and that is Japanese trial. Though the intrahepatic cholangio was clubbed with other tumors, but there is some level evidence that adjuvant therapy will help in patients following the R0 resection. So again, based on this, I will come to the case 1 scenario, which we have a solitary large tumor located in the right lobe of the liver with old lady, 65-year-old lady, because most of the intrahepatic cholangio, they happened in the 5th to 7th decade. So these patients will not tolerate neoadjuvant therapy prior to surgery, and they have good performance status. So we planned for surgery, underwent staging laparoscopy. She had no meds, and we this is an intraoperative picture showing the large intrahepatic cholangiocarcinoma located in the segment 7-8 area. Again, this is again picture. See the background liver. This was the background of the NFLD looking like a cirrhotic. This was the liver resection after marking the dissecting the hilum. This is a parenchymal transection, and this complete following the complete resection. This was the good, well perfused the remnant with good inflow and outflow. So histopathology come to be the intrahepatic cholangioCA, and all margins were negative. The staging was T1B with negative lymph nodes. And she had a background liver was a cirrhotic. Her post-op course was uneventful without any bile leak. Though she was forming some ascites, we managed with drain fluid replacement, and she got discharged. Come to the case 2. Case 2 also, she is a 50-year-old lady with multifocal tumor in the right lobe, one of the central tumor encroaching on the left side of the portical pedicle, and underwent outside right portal vein embolization. She was evaluated in here. She was considered for, because of her, we don't know sure whether high chances that we'll get a R1 resection margin because of the location of the centrally located tumor. So we underwent 6 cycles of neoadjuvant chemotherapy with following the radiation therapy. Again, then she was referred to HBB surgery for surgical resection. She underwent multiple PET surgery during that time. Her disease was stable. There was no extrahepatic disease, and there was a lymph node negative disease. So we considered for the surgical resection. Before surgery also we explained there might be possibility of R1 resection. Her ICG was 6%, upper end of no varices. The upward portal vein embolization, the left lateral was adequately volume. The left lateral was almost 41.4%. She underwent staging laparoscopy followed by extended right hepatectomy with portal vein resection with hepatocogenostomy. These are intraoperative pictures. See the tumor location almost encroaching on this is the left hepatic artery, and there is behind is the left portal vein. This was after parenchymal transection. The left hepatic artery is completely dissected free, but the tumor is involving the portal vein confluence. After doing the portal vein resection with end-to-end anastomosis, the good well perfused remnant with good inflow and good outflow, and this is the final specimen. She was also post-operative course was uneventful, though there was some, because of the received chemotherapy, she was forming ascites, but there was no evidence in bile leak. She also got discharged on day 15. Her histopathology also came as a multifocal tumor, that is intrahepatic cholangioCA, R0 resection, and the portal vein margin was also negative. Lymph node status was also negative. This is a follow-up almost more than 2 years. Now see there is no evidence of any recurrence. The remnant has adequately hypertrophied. So this is the IL-based data from 2004 to 2000, recent up to latest, this one. So there is especially the male predominance, and most of the significant group of patients are more than 60-year-old, which will not be able to tolerate the neoadjuvant therapy. This is a clinical presentation. 6% present with abdominal pain, 5% with loss of weight, 2 patients had a jaundice, so we did a period of biliary drainage to optimize them, and 3 patients were asymptomatic. This is a type of resection. Most of the majority underwent the major hepatic resections with few modified extended right hepatectomy and some extended left hepatectomy, also one central hepatectomy. This was a need of vascular resection. We performed good number of vascular resection, that is 3 patients. Portal vein 2, that was both were segmental resections, and 1 patient we did one portal vein resection, that was a segmental and hepatic artery resection in 1 patient. Also, the few patients required because of 2 patients were jaundice, and because of the location of the tumor, we required to resect the extrahepatic biliary duct also. Only 1 patient had a R1 resection. R0 resection was 94%, and adequate lymphadenectomy as per the more than 6 lymph nodes we performed 56% of the patients. If you see histopathology, significant number of patients had lymphovascular invasion and perineural invasion, and the lymph node positivity. Also had a macrovascular invasion, also was present, almost portal vein invasion, hepatic vein invasion, and combined invasion was there. If you see histopathology, most of the tumors were grade 2, only polar differentiated tumors were 2 tumors. Good number of patients were T2 and T3. This was a background liver. Again, now already sir told the good number of patients we present on the background of cirrhosis, and if you have well-preserved liver function with good ICG, we can directly undergo, because this patient will not tolerate the chemotherapy, they will decompensate after chemotherapy. These are the post-operative complications. Very few number of patients develop significant clinically significant post-operative complications. 5 patients had a grade B grade B post-operative liver failure, and 1 patient had a grade C. All these patients recovered with conservative medical management. We don't had any in-hospital mortality. This is our survival. It is similar to the literature. The median survival is 21 months, 3 years survival is 31%. We don't have long-term data. We have to see this. This is a recurrence-free survival, that is 19 months. This is a recurrence. 28% had a hepatic recurrence, 3 had a extrahepatic, and 2 had a combined recurrence. This was recently operated. Just I will go to one more case. 68-year male patient with abdominal pain and jaundice. Again, he had a high bilirubin of 29, otherwise well preserved, good performance status, CA19 level of 27. This was the tumor. See the tumor location, almost located the centrally, encroaching on the middle hepatic vein. There was a left-sided atrophy was there. Also the tumor encroaching on the portal vein. So there is a large intrahepatic cholangioso involving the segment 4, 2, 3, involving the primary confluence and left portal vein. There was a left after also the enlarged HDL lymph nodes. On PET CT, he didn't had any extrahepatic disease, so we planned for after pre-optimization, we did PTBD. After normalization of the bilirubin level, he underwent staging laparoscopy with modified extended left hepatectomy, caudate resection, bile duct resection, portal vein hepatic artery resection. He had a little bit higher blood loss because of the complexity of the surgery. Duration of the surgery was 11 hours. This is the intra photograph. See the location of the tumor, atrophied left lobe. This was after completion of the resection. This was the portal resection performed, segmental resection. This is the arterial resection, right artery was resected. This is a remnant with well perfused, no congestion. This is the post-operative course was uneven. He also had a grade B post-operative liver failure, but with medical management he also went fine. This was histopathology having multiple satellite nodules and lymphovascular invasion. He had a lymph node positivity. This patient is now undergoing adjuvant therapy. At 3-month follow-up, he is not having any recurrence. So if as compared to the literature data, see our group of patients, they are also 53, male dominance, size is as compared to we have large size 14 centimeter, higher CA19 levels, lymph node positivity also 31%, background liver cirrhosis is 31% as compared to the previous studies. Very good number of patients undergoing R0 resection, and the median survival is comparable despite the poor larger size and high CA19 levels and after doing major vascular resection. So my take home message is that you are able to achieve the R0 resection, let it be T2, T3 or lymph node positivity conform to the HDL, that is the locoregional area. We should go for upfront resection. Patients who have multifocal tumor, multicentric, especially which are located in the bilobar side, who had lymph node positive, poor differentiation, this patient should be considered for the conversion chemotherapy and then go for surgery.